Good evening, everyone. Welcome to the second of our BCF Academy webinars. I hope you can hear me okay. I'm Rachel, one of the vets from BCF Technology, and I just want to say thank you very much for signing in this evening. And this evening we are very lucky to be joined by Jonathan Pycock. John's an equine reproduction specialist, and he has contributed heavily towards progressions in artificial insemination, assisted reproduction techniques, and IVF. He was awarded the Diploma in Equine Stud Medicine in 1994, and in 1995 he became an RCVS recognised specialist in equine reproduction. More recently, in 2012, he was appointed as one of the 3 equine claims consultants for the VDS, and later this year he's going to become BVA President. Throughout this evening's webinar, please feel free to ask questions via your question facility in your control panel. We're going to log your questions and we'll get through as many as we can with John at the end. If you do want to remain anonymous, then please just say so before you start typing your question. So without further ado, I'm going to hand over to John. Thanks very much, John.
Okay, Rachel, thank you very much for that, although it reminds me how old I am. But anyway, good evening, ladies and gentlemen, or virtual ladies and gentlemen. I can't see you, but this evening we're going to talk about keeping the early pregnancy going in the mare, which is a sort of passionate subject of mine. As a clinician for almost 30 years, it's something I feel is very, very important for us to have a good handle on in practice, because I really feel it's a way we can make a positive contribution to getting the maximum number of mares in foal for us. Just at the outset, I would like to acknowledge not only the sort of immediate help I've had from Rachel and Holly in setting this up, but also BCF as a whole, as a firm who've sponsored and been involved in the equine and of course the small animal scene. I can only speak for the equine, but the equine scene in the UK for many, many years, almost since the beginning of us being involved with ultrasound. And I'm particularly excited by the new development they've got, which is the BCF Academy, developing a sharing platform for all case histories and webinars such as this, and I'd encourage all of you to get involved in that as much as you can. Obviously, in a shorter time as we've got, we can't go through a lot of material in detail. And I've always believed, when I'm speaking at a lecture or a congress or whatever, rather than just recite verbatim what's already well written in textbooks, it's better for me to try and give you a personal view of how we approach the particular issue from our practice situation. So I won't be going through reams and reams of written data that is very well documented, I may say, in books that I've been involved with. And in particular, I'm going to use as a source the current therapy in equine reproduction. I co-edited with 2 good friends of mine, Dr. Wan Samper and Dr. Angus McKinnon, and much of the more detailed information you'll see in, sort of alluded to in the slides that we'll go through, will be contained within that publication. So just by necessity of the time frame involved, we can't go through too much of it in enormous detail. But if you do want to source a reference later, you know, I'd signpost you towards, in particular, current therapy in equine reproduction. There's also, of course, Angus and others' massive 2-volume tome on equine reproduction, and in the last 2 or 3 years, a very nice publication, the Atlas of Equine Ultrasonography. So I would just put those up as worthy of your consideration if you want to get some more detail on equine reproduction in general, and in particular some of the things we'll talk about this evening. So what's my credentials for talking? Everybody these days has to give seems we have to give a affiliation slide or something, so I suppose I'll put that up there. My credentials for talking to you are really based on 30 years examining mares at high quality stud farms, like you can see in the slide there. I finally, allegedly I'd done 1 million rectal examinations, but we had a PhD student, my good friend Roger Smith, analyze that, and it is significantly less than that, but we have put it around about 250,000, so I hope that gives me some credence to be able to talk to you. I hung up my rectal glove 2 or 3 years ago and became a claims consultant for the Veterinary Defence Society, swapping my rectal glove for a lawyer's suit. I've also been a little bit of a comedian like Michael McIntyre over the years, but a webinar does, you may be relieved to hear, reduce the likelihood we can make too many jokes, so it'll be a fairly serious 45 minutes, I guess. Oh, hang on, we appear to have found a minor hitch with the, I don't know if everything's working all right for you, if you can see the screen, but no, that was only a joke, sorry everybody. It's my webinar joke attempt. So on to serious business now. So I want to try and get you thinking about things rather than just sitting there or doing whatever you're doing. So I have a much beloved, any of you have been to my lectures, these voting systems, but we obviously can't apply that in this scenario, so I'll just flag up some of the slides I use. So this is one of the introductory slides to get used to the voting or question schemes. So what I want to know here is what statement is false of these 1 to 4 I'm going to give on the left-hand side. So have early pregnancy rates in the mare increased in the last 20 years? Let's have a think. Do less mares lose the early pregnancy now compared with 20 years ago? Have life rates increased in the last 20 years? And do some early pregnancy now compared with 20 years ago? So what statement is false? So it isn't the true one we're looking for, it's a false one. Well, if we look at question or option 1, well, we've actually done a reasonably good job over the last 20 years. Pregnancy rates, you know, say 15-day preg scans, have increased over the last 20 years. They're probably plateauing now, but that's another story, but they certainly have increased. Less mares lose the early pregnancy now compared with 20 years ago. Well, have a think. Those of you who said yes, we'll revisit that. Number 3, live foal rates have increased in the last 20 years. Exactly mirrored the increase in early pregnancy rates over the last 20 years. Now, number 4, the same number of mares lose the early pregnancy now compared with 20 years ago. Well, if we were voting, what I would have expected or hoped most of you would have got was number 4. The same number of mares lose the early pregnancy now compared with 20 years ago. And that's quite an interesting point to make, I think, because it really means, what I draw from that is, we aren't really achieving very much about reducing early pregnancy in the mare. That's not for want of trying. There's been a considerable amount of research done in the area, but we haven't really got, as practitioners, anything concrete we could take through to scientifically apply. And because of that, I think nowhere is the management of early pregnancy loss possibly more anecdotal or more subjective than it is in this case. So I make no apology for that. It is to some extent, you know, we live in a world of evidence-based medicine, but unfortunately, as we'll show you over the next half hour or 40 minutes or so, we're a little bit distinctly lacking in evidence in this field, but nonetheless, those of us who have to work as a living of getting mares in foal, and once we've got them in foal, maintain them in foal, we need to do something. So I'm certainly not an apologist for the anecdotal treatments we're trying, and I want to try and show you how they've been of benefit to us in our practice over the last 20 years or so, in making a significant contribution in, we feel, our practice having a lower early pregnancy failure rate than we would have expected with the caliber of mare which we're working with, and more of that over the next few slides. So let's start with something perhaps we can all agree on, that early pregnancy failure is, without doubt, a major source of economic loss to the horse breeding industry. What do we know about things? I don't want to get bogged down in figures and percentages like I told you at the outset. We can read all those, but I just want to make some points to illustrate the information I'm going to try and pass on. And I'd like you all to bear in mind that in the normal mare, the fertilization rate, the conception rate, I suppose, if you will, is high. Let's just say it's more than 90%. It's probably some way north of that figure, but let's go with more than 90%. However, as with all these things, there's a growing amount of evidence that older mares, not unsurprisingly, may indeed have oocyte problems, which may mean their fertilization rate is clearly not going to be as high as in the younger mare. And I think we'd all accept that that's reasonable enough to understand and grasp as a consequence. So once we've got fertilization rate of whatever it is, 90–95%, we may have some loss along the way before day 6. Why do I pick before day 6? Well, if you recollect your embryology or whatever from your vet school days, the equine early pregnancy or fertilized oocyte, whatever you want to call it, is somewhat unique in that for 5.5 to 6 days it remains within the oviduct, which you can see pictured in the 3 different images along the bottom of the screen. So for the first 5.5–6 days, the early equine pregnancy is within the oviductal environment, and we know that oviductal environment is important, but we can't really get much of a handle on what the precise, accurate incidence of early pregnancy failure within that 0 to 6 days is. When can we first detect pregnancy failure? Well, when can we first reliably detect pregnancy using ultrasound? Well, that slide or that picture might give you a clue. You can look at the scale at the bottom. 6.1 is centimeters, so you can see each little gap between the dots is a centimeter, so you've got around about a 5–6 millimeter structure there, maybe a bit less, 4 or 5 millimeters. And that's when we can first reliably detect the equine pregnancy, and that is an equine pregnancy around about day 11. Now, what's the follow-up question of that? When is pregnancy usually first detected in clinical practice? Have a think. When do you, in your practice, detect early pregnancy? If we could reliably do it at day 11, why don't we do it at day 11? Or do we do it at day 11? Well, we don't, do we really? We know that. We don't usually do that. We usually detect it first off around about 14, 15, 16 days. We don't do it at day 11, 12 because if there's a little bit of sunlight across the screen, or if there was an ovulation 24, 48 hours behind one of the if we had 2 ovulations 48 hours apart, well, if we're scanning at day 11, 12, we're simply not going to see, no matter how good your ultrasound machine is, a pregnancy of day 9 or 10. So we don't, although we can reliably detect it at day 10, 11, we don't scan mares then in routine clinical practice. We do it at day 14 or 15. However, if we did want to get a handle on early pregnancy failure, we can flush the mare day 6 a little bit early because, okay, we said they'd probably come down from the oviduct by then, but maybe not until day 6, 6.5. So that's why, of course, in commercial embryo transfer, we're normally doing the flush around day 7, 7.5. But we could flush the mare between day 6 and 11 and see if we can recover an embryo, and it would be an embryo too small to see with ultrasound. And interestingly, there's a little bit of an aside for you which you may find of interest. In our practice, if we had a mare which we had 3 goes, say, at trying to achieve a pregnancy, and everything looked good in terms of ovulation, in terms of semen quality, fluid disappearing after breeding, and we just failed to get a conception, we may well do a flush of that mare at day 7 just to see if we recover an embryo. So aside as a technique for investigating the subfertile mare, it also can provide us with some information on where these early pregnancy failure losses are occurring. And as I say, I'm not going to go into those figures this evening. If you want to reference them, then I'd steer you towards that Current Therapy in Equine Reproduction book, where these figures are talked about in more detail than we could achieve in a 45-minute webinar session. So at the risk of introducing some percentage figures into it, which can always have little bits of holes picked in, I think it wouldn't be uncontroversial to say between days 14 and 36, estimates of rate of pregnancy failure vary from 8% through 20%. Now, you may think, oh, well, that's quite a big variation there. Well, it is. It is a significant variation. And the point that's made in the chapter which I'd signpost to you in Current Therapy in Equine Reproduction, written by Dirk van der Waal and Johnny Newcomb, makes the point that it's extremely dependent on the age of the mare, and you probably all appreciate that. Younger mares are generally going to have lower pregnancy loss rates than older mares, and that point's very well made in that chapter. Now, what you'll find, of course, is that if mare owners are present when you're scanning the mare at 14, 15 days, they'll wonder why there's likely to be any problem with this pregnancy. Oh, we've scanned the mare in foal at 14 days. I used to see them go forward, mark off, you know, like 11 months on from that. Oh, I'm booking out the day my mare will foal because you've tested her in foal at 14, 15 days. So in, you know, whatever 330 days minus 14 is, she'll go on to produce a healthy live foal. Well, no, that doesn't happen. You've got to think that we're scanning mares for first pregnancy incredibly early, 14 days. Not only that, we're often working in equine reproduction with mares of mid to late teenage years, you know, again, an older mare population. So it would be very naive to think that a mare scanned in foal at 14 days will go on to carry that foal through and deliver a live foal. But nonetheless, you do need, as veterinarians, I think, to communicate that in a reasonable manner to mare owners, particularly mare owners breeding for the first time, who may not appreciate that that's the case. The causes of early pregnancy failure are multifactorial, and the minute you have a syndrome or whatever that's caused by many different factors, it of course becomes difficult to provide a silver bullet for treatment management of the thing, and that's why there clearly isn't one for preventing early pregnancy failure. All we can do is aim to reduce it. Now, let's have a read of this. Our belief is that persistent, unidentified, or poorly treated acute and chronic inflammatory conditions of the uterus are responsible for the majority of problems of early pregnancy failure. Now, have a think about that statement. Do you agree with that? Not agree with that? Maybe you want to know who said that. Is it somebody worth thinking about? Well, it was my good mate Gus McKinnon and myself, and we wrote that in our maintenance of pregnancy chapter 57 in the Current Therapy book. And we firmly believe that that's the case, that a good proportion of early pregnancy failure is when we don't make sure the uterus is free of inflammatory mediators and fluid post-breeding. And it means the post-breeding management of the mare is vital, be that oxytocin, be it lavage, be it antibiotics, be it a combination, whatever. And we can't, in the time we've got available this evening, go into post-breeding management of mares. We'll have to have that for another session. But nonetheless, just remember that, certainly in my opinion, it's a massive part. If you don't clear that post-breeding inflammation, then you are going to put that mare at risk, at considerable risk of early pregnancy failure. Oh, wow, who would want to deal with one of those? Well, unfortunately we have to, and I just really have stuck this slide in to make the point that we don't get our choice over what mares we have to deal with. Quite often the mares people want to breed from are older mares, are mares with poor vulval conformation. Maybe they're their favorite mare, maybe they jumped well, maybe they did Grand Prix dressage, whatever. They want to breed from that mare, so we have to do the best we can regardless. And in view of that, with mares with a vulval conformation like that, it really isn't much surprise that we do get a significant degree of early pregnancy failure. And that's a given, no matter how well we manage these mares in terms of vulval surgery, in terms of management post-breeding. We are going to have to accept, and the owners are going to have to accept, that there is inevitably going to be a degree of early pregnancy failure, and all we can do as veterinarians is try and minimize that to the best of our ability. I don't want to dwell too much on the causes, but just to list them here really, I think we can bracket them into three different categories. Always a bit artificial because, as ever with these things, there's a degree of overlap, but I think there are genetic causes which by and large will arise at fertilization. They could be chromosome abnormalities, and particularly in older mares there'd be aged oocytes. Then we have the uterine environment. There's the question of breeding at foal heat, which would provide yet another topic for a webinar, I guess. Endometriosis, endometrial cysts, and probably I would elevate it to the biggest category or biggest problem category, mares with persistent fluid after breeding. And then endocrine, which we'll tackle later on. Endocrinology of pregnancy is complex, and we certainly can't get into it here in terms of estrogen and progesterone levels. What I want to focus on in the second half is the so-called progesterone dilemma, the benefits or otherwise of trying to prevent early pregnancy failure by use of progesterone, or perhaps, if we're being technically accurate, progestogens. As a definition, perhaps we could have had this earlier. Just for the record, we're not going to get in this session into abortion or later pregnancy loss. We're going to really restrict our session to early pregnancy failure, and let's define that as pregnancy failure that occurs up to day 40 of gestation, and that was felt a reasonable view in that chapter on early pregnancy loss in equine reproduction. We can detect, of course, early pregnancy failure with ultrasound, and we all know the small for age pregnancy. Here we have an example of that. This mare had a synchronous ovulation, so the ovulations occurred at the same time, and this was our first pregnancy scan at 15 days, and already the pregnancy, you can see on the right hand side, is around about 3 to 4 millimeters in diameter, smaller than the one on the left, and that could be a sign that that pregnancy is going to undergo failure. Of course, if we scan this mare at 14, 15 days and discover that image, we will of course crush the pregnancy on the right, because why would we take a chance? But there is a good likelihood that the pregnancy on the right would ultimately fail of its own accord because it is small for age. We also get visualization of pregnancy failure when the embryo fails to appear. I'm a little bit pedantic about this, but of course at 14, 15 days, we aren't, say the slide on the left there, we're not looking at the embryo. This is not, I hope you can see the arrow, but that is not the embryo. That is the conceptus. This is the embryo, this white 2 to 3 millimeter structure, which typically appears in this 4, 5, 6 o'clock position in the ventral part of the conceptus. Sorry, I'll just go back there. In the ventral part of the conceptus. And it normally appears around about day 21, 22. If that embryo fails to appear, that again is an indicator of early pregnancy failure. And over the years, I'd go as far to say that if you've been accurate with your ovulation date and that embryo has not appeared by day 24, well, it's not going to appear. And latterly, we would actually prostaglandin those mares and commence breeding with them again, because we became firmly of the opinion that with a known ovulation date, no embryo by day 24 was a sign that really the embryo just isn't going to appear. This is an interesting slide. Here we've got a mare at 22 days of pregnancy, and I want you to have a good look at this, and you can see the arrow up there is pointing to the embryo. So at first glance we would say, well, here we've got an embryo which has not developed in the 4, 5, 6 o'clock, 7 o'clock position of the trophoblast, and there used to be a feeling that indicated impending pregnancy failure. So as a sort of next question to check you're all awake and not left to make your coffee or whatever, here's a little question. Which of the following in relation to this ultrasound image is not true? The embryo is developing in the normal position. The embryo is normal in size for 22 days. The pregnancy is high risk to fail. The dorsal top of the uterus is marked by the arrow. Well, the answer to that actually is the one that is not true is number 3. This pregnancy is not high risk to fail. What you may not think is you may think the embryo is developing in a 1 o'clock position in the trophoblast. In fact, it isn't, because that arrow, the blue arrow there, is marking the top of the uterus. And this is a nice ultrasound image because it reminds us that although it looks like the embryo is developing in an abnormal position dorsally, it in fact isn't, because this mare's uterus has got rotated round, and the dorsal part of it isn't the dorsal part on your image. It's rotated round to the left. And we must always, always, always remember that when we're ultrasounding a mare, that we're taking a 2-dimensional slice through a 3-dimensional structure. And it's one of the reasons we don't, if we don't appreciate this, that we put ourselves at risk of missing a twin conceptus. So in fact, this embryo is developing in the, it would actually be in about a 4, 5 o'clock position. Interestingly, were the embryo not to develop in the 4, 5, 6 o'clock position, contrary to what's written in a lot of textbooks, I actually don't think that pregnancy is at risk for failing. And in fact, it only happens in around about 2 to 3% of early pregnancies where the embryo develops somewhere other than 4, 5, 6, 7 o'clock. But over 2 breeding seasons, I followed that small percentage of mares where it didn't occur. And interestingly, I think we had 12 mares one year and 14 mares the next year, so 26 mares in total. Actually, none of those mares underwent early pregnancy failure. So I aren't concerned if the embryo does first appear in the 1, 2, 3 o'clock position. But in actual fact, in ultrasounds, I'm trying to make the message there, it isn't actually appearing in uh, abnormal position because that uterus has got rotated on itself. So you might need to, I don't know if any of you want to rerun through the webinar afterwards if you haven't quite grasped what I meant there, but that's a nice little couple of slides. Okay, what's this an ultrasound image of? This is a mare 16 days after covering. There you can see a 15-day pregnancy. What is that pregnancy sitting in? Well, it's sitting in pretty yucky fluid to me. Intensely echogenic fluid. I mean, you know, by and large, I would presume we've got pus there. If we had a look at a video image of that, here we can see, I never edit the ultrasound videos I take, so my usual system is I'll whip up on the left ovary, so, ooh, look, big follicle in a 15-day pregnancy scan. Are we worried about that? Ooh, maybe, maybe not. Oh, look at that, floating in a sea of pus. Amazing how that 15-day conceptus has grown entirely normally, really. I mean, it's a normal size for 15 days. I found that when I first used to see these. Bizarre that in such a hostile uterine environment, that early pregnancy has developed essentially perfectly normally. And there you can see it's literally floating in a sea of pus. Who would do something with that mare? Who would treat her with antibiotics and altrenogeст? Who would give prostaglandin? Who would do nothing with that mare and check her again in 4 or 5 days? Well, maybe just before we got into the answer for that, let's just have a look at an ultrasound image of a mare with a little bit less fluid around the pregnancy and echogenic fluid. Sorry, and non-echogenic fluid, black fluid, which we're always inherently a little bit less worried about, or I am anyways. And a smaller amount, you know, it's pretty much more subtle. You can just see it in that sort of 7, 8 o'clock position in the trophoblast. What do we make of that fluid? What would we do with that mare? Okay, let's forget the mare with the. For now, let's forget the mare with a 15-day pregnancy in a sea of pus. Here we've got a 15-day scan with just that little bit of fluid. Would we treat with antibiotics and altrenogeст, give prostaglandin, do nothing? Okay, I'll tell you what I would do. I would put that mare on antibiotics and then altrenogeст. I would put her on, if I was at the stud farm, I'd give her penicillin and gentamicin. And if I was going every day, I'd carry her on with that. If I wasn't, I would put her on to trimethoprim sulfa. And I would, before we had injectable altrenogeст, I would give a double dose of daily Regumate. These days, I'd probably inject her with the injectable altrenogeст we now have in the UK, at least. I wouldn't give the mare prostaglandin. I'd possibly do nothing and check her in 4 days. But if you're asking me, I would do number 1. So let's move back a little bit from free fluid. Let's say we haven't even got free fluid. We've just got an edema pattern in that mare's uterus. A 15-day scan. Well, a little bit of edema around the early pregnancy scan. I don't know. Hopefully you can see the arrow. Well, I think we can let that go. But if this mare is pregnant base of right horn and we go all the way up the left horn and see that amount of edema, or in the uterine body we see that, not good. I mean, I don't like to see marked edema at the early pregnancy scan. To me, it's indicative of possibly early pregnancy failure. What would I do? Well, I'm going to go up on the ovaries to look at the corpus luteum stroke corpora lutea, aren't I? I'm going to see if I can see an obvious corpus luteum. What would we do with those mares? Who would treat them with anything? Well, yeah, I would. If I saw a mare with widespread edema at a 15-day scan, I would put her on altrenogeст, without a doubt, even if I had an obvious corpus luteum, because I would think there's some kind of attempt to undergo luteal regression. I believe if you get this widespread edema, there's a big risk the pregnancy will fail. Okay, other ultrasound, more modern, or sort of what we may be able to use in the future or here and now. Some of us using Doppler in daily practice. Let's just rewind that if I can. Here we can see a mare. Here we can see a mare. She's, oh, let's say 28. Well, probably more. She's about 35 days, I guess, 34 days. Lovely blood flow to both of these embryos. So both look very healthy. Contrast that with this mare. This mare came for a twin puncher, something we do in our practice. We twin puncher mares where twins had slipped through the net. And this mare, to me, she's about 45 days. Let's just go back to that. 45 days. Lovely blood supply to that bottom embryo, very little to the top, and yet on ordinary ultrasound I couldn't detect. Both had very good heartbeats. So maybe Doppler ultrasound is going to be useful for us to detect impending pregnancy failure. So enough about diagnosis and percentage incidence. Let's cut to the chase. What can we do about early pregnancy failure? Well, here's something. Look, the buserelin enigma. What on earth does that mean? Well, let's start with something uncontroversial. The hormone buserelin is a GnRH agonist. Several studies in cattle have shown a single injection in late luteal phase results in a 10% improvement in pregnancy rate. We don't know why. It may inhibit luteolysis. It may stimulate luteal function. That was done in the mid-90s. And you know, in 2013, look here, published in 2014, a nice sort of review paper from Johnny Newcomb and Andy Peters looking at this so-called buserelin enigma. How does treatment with a GnRH analog decrease embryo mortality? How does it do that? And I'm not even sure we know now, really. Some of us may not even believe it does. I firmly believe it does decrease embryo mortality. Anyways, we did a study to see if a single injection of buserelin could improve pregnancy rate in mares. And here was our trial, 2 trials, 578 mares. So I hope you think that was a reasonable number of mares. 1 mare in each pair injected with a 40 microgram. That's a vial of buserelin on day 10 or 11 for 1 trial, days 8 to 10 for trial 2. And we determined pregnancy rate after buserelin injection, and bingo, significant increase in days 14 to 15 preg rate and in reducing pregnancy loss rate. So it increased pregnancy rate of breeding the first estrus and increased maintenance of pregnancy rates between days 28 and 30. And perhaps most importantly of all, this is just getting the end of the session, but just have a think about this, the increase in pregnancy rates at 2nd and 3rd cycles was greater when we gave buserelin in the mares which didn't get buserelin, compared with the increase we saw at the 1st cycle. Probably not a surprise if you think about it, because by the 2nd and 3rd cycle, whatever, you know, I don't know, none of us know why the mares weren't in foal, but they clearly have got some sort of problem. So it's likely that a treatment which may help prevent early pregnancy failure is going to show more of a benefit in 2nd and 3rd cycles. So I found that very supportive of there being a benefit from a buserelin injection in the mid to late luteal phase after breeding. Johnny Newcomb, along with Andy Peters and a postgrad, did some further work on that. Look at that, 2,346 mares. And he played around with giving half a vial somewhere between 8 and 12 days after breeding. And when the data overall was looked at, significant improvements in pregnancy rate. So please, in your practice, I'm sort of disappointed with the fact that buserelin doesn't seem to have become accepted or used, but just give it a try if you have mare, a mare which is seeming to undergo early pregnancy failure. Just give it a try and see what you find. A little bit of support comes from German workers in 2002, published in Theriogenology, did some work again, finding an increase in pregnancy rate after use of the GnRH analog buserelin in mares. So it isn't only us who found a benefit with it. How do we use it in our practice, folks? Well, any mare with a history of early embryonic death, early pregnancy failure, or that is a likely candidate. She's 19, she's 20, she's got more endometrial cyst than uterus. Day 10, shot of buserelin. All mares on second cycle onwards, bang. If we could persuade the owner to have a go, if she didn't go in foal, we normally would like to get 65–70% per cycle or first cycle pregnancy rate. Not in foal, please let me give an injection of buserelin day 10. Time's getting on, so let's finish with the progesterone dilemma. Having looked at the buserelin dilemma, let's have another dilemma, full of dilemmas. Progesterone, produced by the CL. Let's get some facts we can all agree on to start with following ovulation. Rapid, goes up very rapidly in the mare. And then in the non-pregnant mare, around 14–15 days, luteolysis occurs because we've got prostaglandin release. So, very important at a pregnancy check at 14–15 days, go onto those ovaries. Look for the CL, not only the number, we got 1, and we got 2, and we got 3, but how obvious they are. So, progesterone comes from the CL. Progesterone's involved in maintenance of pregnancy, pregnancy failure. Ooh, maybe we can do something with supplementing progesterone. Well, certainly in the UK, and it may be different in other parts of the world, obviously, but in the UK, we don't really use native progesterone. We use the progestogen, altrenogest, either as the oral form Regulate, or launched this year in the UK, we have an injectable preparation of altrenogest, 3 mils into the muscle every 7 days. Now, let me say at the outset, I know I'm sort of hopefully affectionately known as Dr. Anecdote, but I'm well aware that the majority of scientific evidence suggests that primary luteal inadequacy is not a cause of reduced progesterone levels. Okay, so I've got to accept that. It doesn't mean there's no evidence, but okay, let's go with that. So second point, if using a progestogen, let's at least use one that raises progesterone levels. Some of them just don't do that in studies. Angus McKinnon's done several studies where various progestogens simply don't have any effect in the mare. But altrenogest does. So at least altrenogest does work, or it has a potential to be effective in the mare. Now, I'm not going to go through all the literature here, but possibly, certainly in my mind, the sort of seminal paper that, primary luteal insufficiency is on a little bit of a shaky sand background was Cliff Irvine's paper in 1990, published in EVJ, Equine Veterinary Journal, looking at changes in plasma progesterone from day 17 to 42, and really finding that mares which lost the pregnancy, there wasn't in many cases at all, a drop in progesterone to herald that. Let's skip forward a few years to A very interesting paper I found. I'd urge you all to read this in Equine Veterinary Journal, Caniso et al. Premature luteal regression in a pregnant mare and subsequent pregnancy maintenance with the use of oral altranogest. Really essentially saying that if we did undergo premature luteal regression, then there is a real role for supplementing those mares with a progestogen such as altranogest. And this I would thoroughly recommend you to read. Not only is it excellent that practitioners such as Simon Stamfleet take the time out to write these articles, but it actually it's a very interesting message that's given out there. In Equine Veterinary Education 2015, do I give altranogest to prevent pregnancy failure? So, well worth a read. We can't go through the whole article obviously now because we're about to finish, but I'll just pull up the conclusions of that, and it's worthwhile just reading those. Luteal insufficiency as a cause of early embryonic death in the mare is rare, and the widespread use of altranogest in mares that fail to conceive or carry a pregnancy to term is not evidence-based. Ooh, gosh, we all have to be evidence-based these days, of course. However, in selected cases, the use of altranogest has a positive effect on live foal rates compared to untreated controls. Untreated controls, very difficult for us in practice. You know, if I'm dealing with a mare that I think is undergoing pregnancy failure and I want to put her on altranogest, oh no, let's do an experiment and not put your mare on altranogest. Yes, not going to happen. What do we do in our practice? A mare with a history of early pregnancy failure will get a progestogen, altranogest. Mare with edema at first pregnancy scan will get a altranogest. Mare with a poor quality corpus luteum at the first pregnancy scan will get a altranogest. Yes, over-treating some mares, without doubt. Any downside? I only really think economic. There is a potential for getting infection in a mare, but as long as we're ascertaining that's not happening, I don't think there's any evidence that long-term altranogest treatment is detrimental. And mares will quite happily foal through whilst they're on altranogest. I was talking with Ben Sykes, an experienced internal medicine clinician who was involved in a lot of work on late pregnancy problems, and often those mares would be given altranogest amongst with many other things, and they would foal whilst on altranogest. So I don't see a downside with putting a mare on altranogest apart from economic. And oh yes, gosh, the purists won't like this. There is a feeling that, of course, yes, if we see a secondary CL, we can stop the progestogen treatment. We probably should have progestogen, not progesterone there. But you know, in practice, if I did that at day 60 and that mare aborted or lost the pregnancy, I can picture now that mare owner comes up to you sort of jabbing their finger at you, you know. You took that mare off altranogest. Now she's lost the pregnancy. You should have kept her on it. And they ain't going to listen to any sort of research work. Is that pandering to clients? I don't know. It's management of clients. And those of us earning our living from clinical work, we have to manage our clients as well, you know. So I said, right, this is going to be our system for preventing early pregnancy failure in terms of what we're telling the mare owners. So we decided we'd put them on progesterone till day 100 of pregnancy, try and reduce it from day 100 to day 120, and then reduce it further still from day 120 to day 140. So we used to give out these mare-owned information sheets with our recommendations on, just so we presented as a practice a coherent message. You may not agree with the message, but what I found over 30 years in dealing with mares is owners don't like variation. They like a consistent message coming out from the practice, and this was the message we would give. Don't read the the second paragraph, that's about antibiotics in mares, and we have to be very careful with antibiotics these days. But I do find mares which have are at risk from 4 or 5 months of possibly undergoing a placentitis do benefit from 5 days of antibiotics at the start of each month. But that's again maybe a topic for another day. I think time has got to us now at 10 to 9, so we'll bring that to a halt. I think there is time for questions, but maybe you want to ask your questions in due course to think about them. But if anyone has got a question, I'm happy to take them, or I'm happy to finish.
Thanks, John. That was fantastic, and I'm sure we'll agree a really excellent lecture. We have had 2 or 3 questions come through, so if you just bear with me, I will pull these up and we'll go through them. If anyone wants to ask some last-minute questions, I've got a few popping up now. There is a question facility on your control panel. If you pop them in there, I will read them out for you. Bear with me. So the first one we've got is simply, what drugs, if any, would you recommend using when pinching twins?
Yes, that's an interesting point, and obviously pinching twins and dealing with those is an area where we can get early pregnancy failure, and there's quite a lot of interesting work on what we should or shouldn't do around a twin puncture. I can only really tell you what I do, which is if I felt the twin puncture went okay, I didn't seem to have taken a long time, or there wasn't a lot of fluid ran round one of the conceptuses, I actually didn't give them any treatment at all. I've worked with colleagues who've given them Finidine. I've worked with colleagues who've given them Altrenagest, but for a twin puncture, unless I'm feeling there's a lot of fluid. So what do I mean by that? Well, if I've got a little bit late on doing the twin puncture, if the mare's already at 16 days pregnancy, say, and there's approaching the 2 centimeter conceptus, and I crush that, and I don't know, you'll probably know what I mean if you do any mares. You see that fluid runs round the remaining conceptus. I do have a worry about those, and I put those on Altrenagest rather than a Finidine, because I feel Finidine needs a few hours to have its effect. So if that fluid is going to cause a inflammatory process and a loss of that pregnancy, I rightly or wrongly have the feeling that getting them on Altrenagest will hopefully mean that pregnancy surrounded by the fluid hangs on in there till the fluid is resorbed. So as a general routine, I actually, somewhat surprisingly, you might think, don't give anything for a twin crush. If I feel there's been a lot of fluid produced, I will put them on Altrenagest. Good question though, and there's probably not a right or wrong answer. So I wouldn't encourage you to, if you're getting success with using Finidine or Flunixin, well, carry on with that. But since you asked, that's what I do.
Great, thank you, John. That's excellent. Next question is there any contraindication for using buserelin and progesterone oxygen together? Yes,
well, look, yeah, that's a very good question, really. I mean, the way we use no, I mean, to answer the question is no, I don't think there's a contraindication at all. There, of course, is an argument that is it a bit of duplication. And the way I'd explain that is we generally would use the buserelin at day 10 ahead of picking up a problem. If we scan the mare at day 15, well, let's in most cases say we haven't given the buserelin and we're at day 15 and we see the edema. It's then, of course, or even a little bit of free fluid, it's then, of course, too late to give the buserelin. Buserelin won't work at that stage. So in that instance, we would be faced with putting the mare on Altrenagest. Now, the area which I used to wonder about in practice was when we decided we had a mare that was at risk for losing a pregnancy. So I thought, well, should I just do the buserelin at day 10, or should I really try and cover both angles and put the mare on altrenogest and a buserelin injection? And I would do that in circumstances where the mare owner was happy to pay for that. And I actually would put the mare on altrenogest from day 5 after ovulation. I know some people put the mare on altrenogest from day 0, the day of ovulation, or day 1, but I didn't like to do that because I felt it pushed progesterones up too quickly, and I'm very mindful of exacerbating any residual inflammation, infection, if we push progesterones up too quickly. So I never would put a mare on altrenogest before day 5 after ovulation. And I can fully understand the argument that altrenogest supplementing from day 5 and the buserelin injection at day 10 would appear a degree of overkill. So I can only accept that. But if the owner felt they wanted to do that, we would occasionally do that. But I don't think there's a contraindication between the two. There's just an argument that if you've got the mare on, you should perhaps do one or the other, really.
Okay, fantastic. We've then got a question which says, what are your views on laparoscopic PGE? I'm presuming they mean prostaglandin application to oviducts. Yes.
Well, that's a very interesting angle as well, and we would do around about 4 to 5 PGE injections of the oviducts per year. It's an interesting syndrome, I guess, because it, as far as I understand, is diagnosed as a sort of, well, it's a non-diagnosis in some way. What do I mean by that? Well, when we find with a mare where we're finding no obvious reason why she's not conceiving, we've got no fluid there, we've got no anovulatory follicles, we've got good semen quality. In our practice, I'd probably have tried buserelin in them. Everything appears to be, we may even have done a flush at day 7 to see if we would recover an embryo. And all else is failing. Well, I'm left with thinking this could be an oviduct problem. And if you come to that conclusion, then we would put those mares forward for a PGE injection. But because so few are done, I just don't think we have enough data to know whether it's useful or not. I mean, anecdotally, I would have to look at the figures, but we probably did 4 or 5 per year, of which we would lose follow-up because they'd then go somewhere else the following year. So I couldn't honestly say whether those mares conceived afterwards or not. So I'm always a little nervous. I know Hugh Neal's done some work at Newmarket and written up with Twink, but it's essentially a non-diagnosis, which is always a little bit tricky, I think. But I think it's a worthwhile thing to do with those fairly fussy criteria of 3 or 4 cycles and no pregnancy and no obvious reason.
Okay, thanks for that. Another question, how do you recognize a rotated uterus on your ultrasound scan?
Well, yes, that's a good question.
I think it was one of your slides earlier.
Yes, it shows you've been listening. Thank you, everybody. Yes, you've got a dorsal thickening of the uterus, 2 to 3. It's significantly thicker than the ventral margin. So that's how I could tell on that. If you want to go back later and look at that slide, you'll see what's round in about the 9 o'clock position, because it's got rotated, is thicker than what is at the top, and the dorsal margin of the uterus is thickened, and that's how I always use that as an orientation. If the thickened part of the uterus is not appearing dorsal, it means that you've got uterine rotation, and it was just a nice reminder, and something which we always need to be reminded of when we're ultrasounding mares, that we are looking at this 2D picture of essentially what is a 3D structure. So yeah, that's a very good point there, folks.
Excellent, thank you. Next one is a slightly more practical based question. We've only got a couple of questions left.
Okay.
This somebody is asking, what would be the best recommended management for a 17-year-old Hanoverian mare? She's had a long estrus, follicles ovulating at 38 millimeters, and after breeding she gets oxytocin after about 3 hours of cover.
Good. Yeah. Yeah, well, that's, I mean, yes, you're doing all you can to manage the, you know, we have to accept that any mid to late teenage mare is a greater risk for losing, well, it's a greater risk for not conceiving, and it's a greater risk for not going in foal. And you have to have that dialogue with the mare owner, I think, to, you know, it's always a fine line between appearing pessimistic and realistic. And you have to have that conversation that we're not dealing with a particularly fertile mare, and all you can do is maximize your chances by the post-breeding management, which it sounds like you're doing. And as I said in the talk there, I'm convinced that post-breeding management and trying to ensure we don't have any persistent fluid, it's absolutely imperative to preventing early pregnancy failure. So I'd manage the mare with your oxytocin, maybe even a lavage, whatever. And then a mare of that age, yes, I would certainly give her a buserelin injection at day 10 as my first line. And you know, it's not there's no, as far as we're aware, there's no downside to that. It's not, you know, hideously expensive, and we found it certainly, well, I'm going to say we found it gave us a better pregnancy rate. We worked that out in the trial. Of course, I can't tell you in your specific mare it'll be better or not, because you're not going to have a control. But the buserelin work, we did have a significant you know, number of mares involved, and there were inbuilt controls because it was done on a rotational basis. So that would be certainly what I would do. I would do the excellent management. Sounds like you're doing treating after 3 to 4 hours, oxytocin, maybe a lavage, and then I would give a buserelin shot at day 10 after ovulation, and fingers crossed. And if I scanned her at 14, 15 days and I had the pregnancy, but I wasn't very happy with the corpus luteum, or I thought there might be a little bit of fluid, well, then I'd probably put the mare on Alchanogest as well. So you'd have to let me know if it works. Don't tell me if it doesn't work.
Great. Great, thank you, John. Our last question, which actually ties in quite nicely with that one, is a question asking, would you use the full dose of buserelin or a half dose as described in the article? I'm not sure of the conclusion in the article. I think they might be referring to the one earlier.
Yes, yes. I always used, and we have stuck with, the full vial. Probably the only person who could answer the question about the half vial very accurately would be Johnny Newcomb, who's done the work on that. I've read John's papers on it, and that paper in particular that I put up there, but he has done others, and he seems to think the half vial is just as effective. I wouldn't like to comment any further than that, because it's not something I've done. I've remained with the full vial of buserelin. So I remember the full vial, but there does seem to be evidence that a half vial, 20 micrograms, would be sufficient. But I'm only quoting his data. So if you ask me what I personally have done, I've remained with using the 10 ml vial, 40 micrograms.
Okay, perfect. That is all of our questions for this evening. Thank you everyone for signing in, and massive thank you to John for giving us his time this evening. This webinar will be available to view on our website hopefully within the next 24 hours or so if you do want to watch it again. Just a reminder to everyone that doesn't already know, we do have our BCF Equine Imaging Facebook page. You can search for that just through Facebook, and we'll pop the link up on there for you all as well. So that's all from us. Thanks everyone again, and I do hope you enjoy the rest of your evening. Take care everyone.